I'm starting the series of lectures in the topic of neonatology, and the first module is about normal newborn. In this module, I'll be discussing about certain characteristics of a normal newborn baby and some appearances in the normal newborn and how to take care of a normal newborn baby. Let us get started with few definitions in this section of normal newborn. We will start with what is called as newborn period. We all know that the first 4 weeks after birth is what we call it as the newborn period. And in the first 4 weeks, the first week is defined as early newborn period, and the next 3 weeks are defined as late newborn period. Okay, this is a subdivision in the newborn period itself called as early and late newborn period. Then talking about birth weight. Average birth weight of a baby in India is around 2.9 kilograms. And if the baby is less than 2.5 kg, it is called as low birth weight. If the weight is less than 1.5 kg, it is called as VLBW, which is very low birth weight. And if it is less than 1 kg, it is called as ELBW, which is extremely low birth weight. So these are definitions which corresponds to a baby which is less than the expected weight. We can also have on the other side a baby who is having more weight than expected. What you call that? You call it as a big baby, or it is also called as a macrosomia. Somia refers to the body, and a baby which appears big in size is called macrosomia. Macro means big body, which is the meaning of a big baby. A weight of more than 4 kg at the time of birth corresponds to a big baby. These are the basic definitions in the newborn period with regards to birth weight of the baby. The next thing to be remembered is that birth weight should always be interpreted with relation to gestational age. So that is why we are having a chart which tells you about the relationship between the birth weight and the gestational age, and the name of this chart is what we call it as intrauterine growth chart. Okay, just like any other growth chart, here also you would be having the curves which are the percentile curves. We need to have a reference curve for a lower value and a reference curve for the upper value. In this particular chart, you can see that the lower reference curve is the 10th percentile and the upper reference curve is the 90th percentile. Any value of weight above the 90th percentile is called as LGA, which is nothing but large for gestational age. L stands for large, G stands for gestational, and the A stands for age. So it's called large for gestation age. Any baby whose weight is more than 90th percentile is called LGA baby. Any baby whose weight is between the 90th percentile and the 10th percentile is something which is normal, or what we call it as AGA, which is appropriate for gestational age. A here stands for appropriate for gestational age. And any value which is below the 10th percentile is called as a SGA baby. Here S stands for small for gestational age. Okay, so remember, always we need to interpret the birth weight of the baby in accordance to gestational age into LGA, AGA and SGA. Now let us look at some conditions why the baby appears as a small baby or as a large baby. Let us start with a small for gestational age. Okay, now whenever we talk about a baby who is appearing small, the reasons is not always due to a problem. That is the first point to be remembered. It can also be a normal variant. Very important. That is why you can see that there are 2 categories of small for gestation age. One is normal variant baby and the other one is IUGR baby. Normal variant baby is also called as constitutional small for gestational age. Constitutional small for gestation age. Whereas IUGR baby, what does IUGR stand for? Intrauterine growth retardation. or we can also call it as intrauterine growth restriction. It is always associated with some pathology. Okay, right? Whereas constitutional type of SGA is a normal variant, which is more common. Constitutional small for gestational age is always more common when compared to intrauterine growth restriction. This is the first learning point to be remembered. Now, you have a baby who is small for gestational age. How do you differentiate whether this baby is a constitutionally small baby or a IUGR baby? There are some features in the baby which will help us to identify this. Intrauterine growth restricted babies have loose skin folds. According to the criteria, at least 3 loose skin folds should be present to call a baby to be suffering from intrauterine growth restriction. Number 1. Number 2, the placenta would appear thin. Even the umbilical cord also would appear thin. Okay, this is not a very important distinguishing point, but just an additional point to be remembered. Third important thing is, if you look at the head circumference and compare it with the chest circumference, normally we know that at the time of birth, head circumference is more than the chest circumference. However, the difference is around 3 centimeters. In a baby with intrauterine growth restriction, what happens? There is a big difference between the head circumference and chest circumference, in the sense that it would be more than 3 centimeter of difference. Remember, the normal difference is only 3 centimeters, but in a baby with IUGR, generally the difference is more than 3 centimeter. Okay, right. This is how you differentiate whether it's a IUGR baby or a constitutionally normal baby. Clear? Okay, now we move on to what are the conditions which can be associated with intrauterine growth restriction. Okay, when we talk about the causes of IUGR, there are always 2 things which comes to our mind. One is maternal conditions, other one is a fetal conditions. Okay, the maternal condition would include all the disorders under the category of uteroplacental insufficiency. Okay, uteroplacental insufficiency. The classical example of uteroplacental insufficiency would be a condition like gestational hypertension, okay, which would result in uteroplacental insufficiency. Okay, right. Now, this category of disorder is more common when compared to the fetal causes. Okay, that's an additional point to be remembered. So, maternal causes of IUGR or uteroplacental insufficiency is more common compared to fetal cause. Let us see when this is going to have an onset during the pregnancy. Okay, generally the maternal causes have an onset during late trimester. What I mean by late trimester, in the 2nd or in the 3rd trimester, they have an onset. Okay, now what is going to be the effect on the baby? Think like this: till 2nd trimester, the baby was growing well, and after that there is a placental insufficiency, because of which the blood supply and the nutrient delivery to the baby becomes less. Okay, now the baby's body undergoes adaptation in the form of something called as brain sparing, where growth of the brain alone will be spared, but the rest of the organs would suffer. This is what we call as a brain sparing effect. Because of the brain sparing effect, what would happen? The head size would appear to be normal, whereas rest of the body would appear to be small in size. Okay. Now you can very easily notice that in the baby there would be a discrepancy with the head size and the rest of the body. So this type of IUGR is called as asymmetric IUGR. Okay, because there is an asymmetry between the head and the rest of the body, we'll call it as asymmetric IUGR. So this is the first type of IUGR which you should know about. This is more common compared to the other type. Okay, right. Moving on to the second cause, which is the fetal cause of IUGR. Okay, now in this particular condition, the disorders could be in the baby itself. For example, some genetic defects in the baby, or something like anomalies in the baby could be associated with a fetal cause of IUGR. Okay. Now, this type of IUGR will have an onset in the early trimester. Early means first trimester itself, it would have an onset. Because the IUGR starts very early in the gestation, there is no time for brain sparing. So, there is no brain sparing effect. Because of which, every part of the body would undergo growth restriction. So, from the head to foot, every part of the body will be small in size. This is what we call it as symmetrical IUGR. Okay, symmetrical IUGR. Okay, the second type of intrauterine growth restriction. Okay, so as you can see, maternal cause of IUGR results in asymmetric IUGR and fetal cause results in symmetric IUGR. I told that the maternal causes are common, so obviously asymmetric IUGR will be more common compared to the symmetric IUGR. Okay, there is a way to distinguish between symmetric and asymmetric IUGR based on some mathematical calculation which goes by the name of ponderal index. Okay, we can abbreviate it as PI. Ponderal index is calculated as weight in grams divided by length of the baby in centimeters cube into 100. Okay. Now, based on the value, we can divide the IUGR into asymmetric and symmetric IUGR. How? A ponderal index of more than 2 corresponds to symmetric IUGR. Okay. And ponderal index of less than 2 corresponds to asymmetric IUGR. This is how in a baby with IUGR we can distinguish whether it's a symmetric or asymmetric IUGR. Having discussed about IUGR and small for gestational age babies, let's move on to large for gestational age baby. What is the definition of large for gestational age baby? Any babies whose birth weight is more than 90th percentile is called as the large for gestational age baby. I have already told you this. Let us look at what are the causes for LGA baby. Number one cause is again a normal variant, or what you call it as constitutional LGA. That is number one cause. Number two is a very, very important condition which I will be discussing in a detailed way in a separate module later on. That is infant of a diabetic mother. Infant of diabetic mother. At this point, it is very important to note I am talking about gestational diabetes and not overt diabetes. Only a baby born to a gestational diabetic mother can have LG. Okay. Number 3 is a condition. It's a rare condition, but you should know for your exams. Is called as a Sotos syndrome, which also goes by the name of cerebral gigantism. Cerebral gigantism, where the baby, in addition to appearing as a LGA baby, also has got intellectual disability, premature tooth eruption, and along with that also has developmental delay. Okay. These are the characteristic features of Sotos syndrome. And number 4 is another important condition and has been asked recently in the competitive exams, which goes by the name of Beckwith-Wiedemann syndrome. The characteristic features of this Beckwith-Wiedemann syndrome is given in this picture, where you can see the baby appears big in size. Number 1. Number 2 is the presence of this big tongue which is coming out, what you call it as macroglossia. Number 3, you can see the picture below which has a swelling like this coming out from the abdomen. What do you call that? Yes, you call it as omphalocele. Omphalocele. Sometimes instead of omphalocele, they can have umbilical hernia. Both omphalocele and umbilical hernia are examples of anterior abdominal defects. Okay. And what is the last picture depicting? It is depicting the legs of a baby with Beckwith-Beaman syndrome, where you can see that this side appears to be much bigger in size compared to the other leg. So one side of the body appears bigger compared to the other side. What you also call it as hemihypertrophy. Okay, you also call it as hemihypertrophy. These are the characteristic features of Beckwith-Wiedemann syndrome, which is an example of a large for gestational age baby. And in this condition, you should also remember that they have an increased risk of one tumor, and that is Wilms tumor. Okay, these are the features of Beckwith-Wiedemann syndrome that you should know for your exams. So these are the important causes of large for gestational age babies. Okay. Having discussed about a big baby and a small baby, we now turn our attention to gestational assessment of the baby. Generally, we know that babies are divided into preterm babies, postterm babies, and term babies according to the gestational age. We all know this and must have learnt in our OBG classes itself. Any baby till the end of 36 weeks of gestation, that is 36 weeks and 6 days, is called as a preterm baby. Any baby from 37 week onwards to the end of 41 weeks, that is 41 weeks plus 6 days, is called as a term baby. And anything from 42 week of gestation onwards, you call it as a post-term baby. And how is this weeks of gestation calculated? You all know that it is calculated from the last menstrual period, which is primarily an obstetric topic which you should have learnt in great detail. Now, from a pediatric point of view, what I am going to tell you is about postnatal assessment of maturity. Okay, postnatal, that is after birth, how are you going to assess the gestational age of the baby? Okay, suppose the baby is there in front of you after birth. You don't have any details about the last menstrual period. You don't have any details about the first trimester antenatal ultrasound. Then how can you determine the gestational age after the birth of the baby? It is given by a very, very good and a very expanded scoring system. What we call it as the Ballard scoring system. What we are using is not the original version but an expanded version of the same. It goes by something called as ENBS. What is this? This is expanded new Ballard scoring system. That is what is called ENBS. Expanded new Ballard score. Okay. Right. Now, for this scoring purpose, we take into account two set of features. One is the appearance of the baby, or the first criteria is something called as a physical maturity of the baby. The next one is neurological assessment, or what we also call it as a neuromuscular maturity of the baby. Neuromuscular maturity of the baby. You can see from this picture, okay, which tells you about the different parameters under the neuromuscular maturity as well as the physical maturity. There are so many parameters, okay, and you can see the scoring system has got values ranging from -1 to +5 for each of the parameters. So lot of parameters as well as lot of scores. You are not required to remember all the parameters of physical and neuromuscular maturity. Instead, you should have a broad idea about this scoring system. You can notice that for this particular score, okay, the total score I'm talking about ranges from -10 to +50, okay. And can you see the range of gestational age covered in this scoring? -10 corresponds to a score of 20 weeks of gestation, whereas 50 score corresponds to a score of 44 weeks of gestation. So if somebody asks you, what is the range of gestational assessment according to this Ballard scoring, your answer should be from 20 weeks to 44 weeks of gestation. Okay. And what is the score range if they ask you? The score range is from -10 2 plus 50. Okay, minus 10 corresponds to 20 weeks of gestation, plus 50 corresponds to 44 weeks of gestation. Values in between correspond to the different weeks of gestation as well. So this is a very good scoring system which will cover a wide range of gestation from 20 weeks to 44 weeks of gestation. And if they ask you what is the accuracy of this scoring system, it is accurate to plus or minus 1 week of gestation. So accuracy wise also this is a very good scoring system for you to know about, and it's a very potential question to be asked in the exams. Based on the physical appearance of the baby, we can try to differentiate preterm baby from a term baby, which I have put up as a tabular column for you. First thing to be noted is about the posture of the baby. Remember like this, a preterm baby always keeps the limbs very straight, hands very straight like this, legs very straight like this. Or what is this posture? This posture is nothing but extension posture. Whereas if you look at a term baby, the term baby always keeps the limbs like this, upper limbs and lower limbs like folded way. What is this folding? It is flexion. Okay, that's a first point of difference between preterm and term baby. That is with respect to the posture. Posture is extension in a preterm baby, and this posture is flexion in case of a term baby. Okay, right. Now the reason for extension posture in a preterm baby is attributed to less tone, whereas a term baby has a good tone. That is why it is able to keep all the limbs in flexion. Okay, and this posture of a term baby, where all the limbs are kept in flexion, is called as attitude of universal flexion. It is called as attitude of universal flexion in a term baby. Okay, so that is first distinction between preterm and a term baby. Second thing is scarf sign. What you do, think like as your hand, and think the left side like this hand as a baby's hand. What you do with your hand, you try to pull the baby's flexed elbow. Okay, baby with the flexed elbow, you try to pull the hands to the other side. Generally, remember, you will not be able to pull completely to the other side, or in other words, the elbow will not generally cross the midline and go to the other side. Remember, this is because of good tone. Okay, think about preterm baby. Okay, you are trying to pull the baby's hands with your fingers. What will happen if you just pull like this? The elbow will easily cross the midline. The reason is because the baby has less tone. Preterm baby has less tone. So what happens? The elbow will easily cross the midline if you just try to pull it away. Okay, right. And this is something like this movement, okay, which is like putting a scarf. So this is also called as the scarf sign. So if there is a question in which group of baby is scarf sign positive, scarf sign is positive in preterm babies. And what is the meaning of positive scarf sign? Elbow crosses the midline, which is noted only in preterm babies. Okay, right. So scarf sign is positive in preterm. What is the meaning of that? Elbow crosses the midline. Okay, whereas in a term baby, scarf sign is negative, or in other words, elbow does not cross the midline. Okay, yes. Okay, third one with regards to the prominence of the breast bud, or what we also call it as the breast nodule. We define it by some numbers. When it is less than 5 millimeter in size, it's a feature of preterm. More than 5 millimeter is a feature of term babies. Okay, then with regards to external genitalia, in a preterm baby external genitalia for male babies, it is the scrotum region which we have to look for. Scrotum appears to be light, that is not very pigmented, and there is very less or even absent rugae. We all know that rugae refers to the markings on the skin of the scrotum. Very less or absent rugae in a preterm baby. And remember, if you palpate the scrotum, the testis may not be palpable. The reason, we all know that testis descends into the scrotum only by 36 weeks of gestation. So baby before that, that is a preterm baby, may not have a palpable testis in the scrotum. because it is not yet fully descended into the scrotum. Okay, whereas for a term baby, the scrotum appears to be pigmented. Okay, pigmented, and will have lot of rugae, and definitely testis is palpable in the scrotum. Okay, right. Next thing is regarding female external genitalia. In a preterm baby, you can see two skin folds in the external genitalia. One bigger skin fold called labia majora, other one is a smaller skin fold called labia minora. Both will be visible in a preterm baby. Labia majora and minora are visible in a preterm baby's external genitalia. Whereas in a term baby, only labia majora is visible. The reason being, labia majora covers the labia minora. Okay, so in a term baby, only labia majora is visible. Okay, this is with regards to the difference in external genitalia. Next one is regarding the ear recoil. Okay, ear recoil is gently by folding the ears and looking for the response. Once you fold the ears and take your hands off, it recoils back quickly because of the elastic cartilage. Okay, now what happens in a term baby? It is the same way only because the elastic cartilage is well developed. So once you fold the ears and take your hands off, it will go back quickly, or ear recoil will be fast in a term baby because the elastic cartilage is well developed. Whereas in a preterm baby, the elastic cartilage is not well developed. So what is going to happen? Once you fold the ears also, it will go back slowly to its original position. Or in other words, ear recoil will be slow in a preterm baby, whereas ear recoil is definitely fast in a term baby. Okay, now the last point of difference is with regards to lanugo hair. Okay, lanugo hair. Lanugo hair, it's a very fine form of hair, soft, what you also call it as the fetal hair. It is usually abundant in a preterm baby, and it is usually sparse or even absent in a term baby. These are the points of difference as to how to differentiate between preterm and a term baby. There are also some ways by which we can identify if the baby is postterm. Postterm refers to a baby born after 42 weeks. That is, from 42 week of gestation onwards, you call it as postterm baby. What are the features? Number one is presence of meconium staining over the nails, fingers and the baby's body. Generally, remember, after the term gestation is over, that is from 42 week onwards, the anal sphincter opens in utero itself and the baby passes meconium in utero itself. That is why it can cause meconium staining. Okay. Number two, if you look at that fingernails and all, okay, the fingernails would have overgrown the edges. Okay, right? So it is overgrown fingernails. Okay, right. And third important point is that from 42 week of gestation onwards, the amount of amniotic fluid will start decreasing, and that would cause appearance of skin wrinkles. Okay, so the baby skin would show a lot of wrinkles. These are three features which may tell you that probably the baby is a post-term baby. Okay, right. So that is about how to identify on physical appearance a baby is preterm, term or post-term.